Welcome to the ECG webcast on physician compensation. I'm Matt Nolan, a senior manager with ECG's Midwest Healthcare practice, and I'm pleased to be your moderator for today's session. Before we introduce today's speakers, let's go over a few details about the webinar. It is 60 minutes in length. The first 50 minutes of the program is a presentation, followed by a 10-minute question and answer session. Everyone should have received a copy of the session handouts, but if you are a late registrant, you can download the handout in the handout pane on your screen. Note that attendees are participating in listen-only mode, but if you have questions, you can type them into the question and answer pane located in the toolbar on the right of your screen at any time. At the end of the formal presentation, our speakers will answer as many of your questions as possible. Finally, upon exiting today's program, you'll be directed to an electronic survey. Your feedback is important to us, so please take a minute or two to complete this survey. We will also make a donation to Doctors Without Borders for each completed survey. Now let's meet our speakers. Josh Halverson is a principal in our ECG's Dallas healthcare practice and works with hospitals, health systems, academic medical centers, and physician groups. Josh has a specific expertise in physician organization development, compensation planning and incentive design, and service line physician organization management. Welcome, Josh.
Thanks, Matt.
Our next speaker is Maria Hayduk. Maria is an associate principal in our Midwest healthcare practice and has extensive experience in physician compensation planning, medical practice development and operations, organizational performance improvement, and academic medicine. At ECG, she is responsible for the proprietary research and custom survey practice. Maria, welcome.
Thank you, Matt.
Before I turn things over to Josh, let's take a few moments to review today's agenda and a little bit more about ECG. So for those of you who don't know, ECG is a comprehensive healthcare company. We have 4 key competencies of strategy, finance, technology, and operations. And we look to consider ourselves as strategic advisors to both pediatric and adult organizations throughout the country. Regarding today's agenda, we will start off with the physician compensation environment, and then we'll get into a discussion on some of the interview findings from our physician survey. We'll then get into physician performance trends, and we'll wrap things up with a discussion on advanced practice provider, or APP, performance trends. And with that agenda in mind, Josh, will you please start the presentation off, and we'll go from there.
Thanks, Matt. I look forward to this conversation. So I wanted to start off with giving the listeners a perspective on compensation. We feel compensation to providers and physicians particularly is a key element that drives the culture of an organization. A compensation plan really supports and has to be linked to an organization's strategy by creating incentives around a mission, vision, and its values, creating alignment between the organizational priorities regarding access, recruitment, and other types of payer initiatives. It also must support a care model that is consistent with what the organization is trying to create. So an example of this is when many of our organizations look at compensation, they think of a care model that they migrate towards a more team-based approach, but have a very individualistic approach to compensation. And when providers are not willing to work in teams, we can look at a compensation plan and see that as a barrier. Compensation also drives organization and operational structure and processes, so things that are associated with revenue cycle, registration, scheduling, other types of things, utilization of technologies, tools for measurement and reporting capabilities. Those are all elements that compensation drive. So to us, getting the compensation right is critical to the success of an organization. So moving to page 7, we're living in really challenging times as healthcare providers. There are significant changes that are happening right now. So traditionally, healthcare has really been organized in I would say, a siloed environment where providers are pretty autonomous They are focused on specialties and systems are decentralized, and lots of decisions reside at the local level. We reside also in a predominantly fee-for-service arrangement where reimbursement is based on value or volume rather than value, and there's segregation or segmented leadership when we think about how hospitals and physician organizations work together or don't work together. We're in the midst of a significant disruption where we think about reimbursement changes tied to cost of care, bundling of payments, other types of things. MACRA, which we will talk about, has been recently introduced. A word that we don't have on this is Trump. The new administration is going to have a significant impact on how we think about healthcare, and lots of organizations are trying to figure out if there are implications with that. The result of all these disruptions is we're moving to a much more value-based environment where we think about making sure the patient is receiving the care in the setting of treatment by the right provider at the right time. And organizations are trying to configure themselves and reorient themselves to deliver that value. And compensation systems really have to support that transition. Moving to slide 8, there is a significant amount of resistance or I guess skepticism amongst our clients regarding the movement from a fee-for-service reimbursement world to more of a value-based world. Recently, CMS articulated significant goals where they said that they are looking to move away from fee-for-service and increase the amount of reimbursement tied to value. And so these pictures or these bubbles really indicate the magnitude of change that CMS is expecting. I think this is an area that is up for grabs a little bit when we think of the new administration coming in. There's been some signals by the new administrator for HHS that perhaps there's some skepticism around this movement towards value. That being said, there's significant momentum to really reduce utilization of services and other types of things to bend that cost curve down. So we actually think that while mechanically there might be some nuances or some slight deviations from what was expressed in the previous administration, the overall movement towards value is going to happen and perhaps even accelerate. Moving to slide 9, MACRA is still going to be preserved even under the new administration. It is, as we all know, an initiative that was supported by a large bipartisan majority of Congress, and what it introduces is a significant change to how physicians are reimbursed. As we all probably know, there are 2 tracks, the MIPS tracks and the APMs tracks. All of these represent, and while we won't go into detail here, is a significant movement and an introduction of dollars and incentive dollars that are tied to value or things other than productivity. And so the point of this slide is to really recognize that the movement towards and away from a fee-for-service only reimbursement system is well on its way, and compensation structures need to keep up. On page 10, we are introducing a couple other variables into this complex equation when we think about how compensation really ties to an organization's economics. We spent a few minutes on those last slides talking about how reimbursement changes are imminent and will be changing things. At the same time, we have significant economic pressures. This slide illustrates what we're finding in our surveys, that there's a significantly increasing investment or loss per physician that organizations are experiencing. There's been a significant amount of consolidation and acquisition of physicians by hospitals and health systems. And so when we look at what is reported to be the loss per physician of about $224,000 per physician in 2016, many organizations have increased the number of heads or number of physicians that they employ, and so that that number, while pretty significant at 50 physicians, is only accelerating when the organizations that we're working with have 100, 200, 500, even 1,000 physicians. And so really questions about economic sustainability are really coming to the fore. I did also want to caveat this slide by saying that there are a variety of variety of factors that impact these numbers, things like specialty mix, payer mix, how overheads are attributed, where ancillary services are recognized, things like that do impact this slide. That being said, we are seeing through anecdote and other experience that compensation is driving a lot of this increase. So again, lots of organizations are looking at compensation as a way to make sure that we are not only creating competitive payment levels, but also creating sustainable financial performance. Moving to slide 11. The response to these pressures, both financial and payer changes, has been interesting. And I would say what this continuum or these three charts represent are how physicians are organized within either a freestanding physician organization or an integrated system. On the left-hand side, when we look at the federated approach, this is how physicians have been organized historically, or even lots of places today, where the physician organization is really a loose collection of individual practices or departments that have a lot of autonomy in terms of what their governance looks like, how they're operated, what management systems they have, and what compensation structures they have today. That has been a very attractive approach. It gives a lot of autonomy and decision-making authority to physicians and department leads, specialty areas or practice areas. There hasn't been a lot of people getting into each other's business. The challenge with this, though, is that it's a really expensive way to run a railroad. There's lots of duplication of services. There's variances on how practices are operated. Staffing patterns are not well regulated. Things like that create significant amounts of financial cost that organizations are carrying. It's also extremely difficult when you think about trying to manage populations of patients. Think about the introduction and adherence to care protocols, other types of things that are important, both in our evidence base in terms of actually showing that improving patient satisfaction and patient outcomes. So those kinds of things are really hard to do under the federated model. So most of the organizations we're dealing with now are trying to move as quickly as they can across the continuum towards an integrated or even more multi-specialty approach. This has significant implications on compensation, where under the federated model, those decisions around compensation design and structure really resided at the department or specialty level. When we think about moving more toward integrated or multi-specialty approaches, those compensation frameworks need to be much more consistent, and the methodologies by which physicians are paid have more common elements to them. And so many of the organizations we're working with right now are moving and viewing compensation much more as an integrated or system-wide discussion rather than a series of individual departments. Moving to slide 12, what this slide is indicating is even those organizations that are looking to greater consistency and more common approaches to compensation, there is a recognition that we need to think about compensation differently for the different types of specialties. And so what this is indicating is that most organizations think about compensation in two buckets. The first bucket being a variable component of compensation that compensation varies based on some definition of performance. The other bucket is a fixed component where compensation doesn't change. And so when we think about compensation structures and how those would apply to different specialty types, the ratio of fixed to variable is often a really key element to think about. And so, for example, when you have a coverage-based specialty like emergency medicine or other types of things, it's very common to have a shift-based approach where physicians are compensated based on time units rather than productivity or other elements that they frankly don't have a lot of control over. On the other extreme, when we think about production-based specialties where physicians have significant impact over scheduling or productivity, it makes a lot more sense to have variable compensation tied to productivity or elements that physicians can control. That all being said, when we think about variable compensation, and we'll see this later in the survey under Maria's slides, lots and lots of organizations are spending a lot of time figuring out what other elements of performance make sense to tie compensation to other than productivity. So the value component is the area of significant attention and planning. We also think that these buckets of compensation can really be seen as variables that you can dial up or down based on the reimbursement realities of an organization. So today, if an organization's reimbursement is 95 or 95+% fee for service, it makes a lot of sense to have a significant component of compensation tied to productivity, for example. As that changes and perhaps more and more value-based reimbursement comes through the revenue door, perhaps that ratio of value to productivity changes and you dial down productivity and dial up compensation tied to value-based metrics. Slide 13 really shows what that transition can look like that many of our organizations are moving towards. When we think about kind of status quo, most organizations still have primarily productivity-based plans. The first step, perhaps, is recognizing that they want to move to and introduce other non-production-based incentives. And so perhaps the first step of that would be having a transition year where you're modeling during, even though you keep your 100% production-based plan, you're modeling and performance testing the other elements of compensation and creating shadow reports to report out what things would be like if and when that is implemented. The third circle really introduces those non-production-based incentives into the plan, where production compensation is reduced, funding for non-productivity-based incentives are established, and incentives, those non-production-based incentives grow perhaps year by year, depending on what happens. We do think that over time, a more balanced approach to compensation will likely emerge, where we have production being an element of compensation, non-production-based incentives being a larger component of compensation, and even introducing fixed amounts of compensation into some specialties. We do think that this kind of more balanced approach is likely going to emerge and take some time to emerge, and the size or proportion of these pie slices may be different depending on specialty type, but ultimately this is what most organizations are really moving towards. On page 14, we are really trying to outline what are the key elements of a highly functional compensation structure. We think that a compensation plan has to address governance and management. How are decisions made? How do we set the priorities of an organization and align the mechanics around those priorities? We need to recognize that there's perhaps a differentiation by specialty, by care setting. Ambulatory is different than a hospital-based or coverage-based model specialty. So those compensation models must reflect those and keep those intact. Work standards and expectations are key elements that I think are more and more becoming questions that our clients are asking us, meaning, what is the workload of a full-time clinical primary care physician or emergency medicine physician? How do we utilize APPs, and how are those compensation? How is supervision of those APCs embedded into physician compensation structures. To us, all these variables need to accomplish two things. They need to result in compensation levels that are competitive, but also economically sustainable, all while maintaining compliance with STARC and other regulations regarding fair market value and commercial reasonableness. My last slide, on slide 15, is just an acknowledgement to say that we've talked a lot, and we will continue to talk about compensation a lot today. Compensation, from our perspective, can't be seen as a Swiss Army knife or some sort of solve-all. It can't solve every problem. Rather, it has to be recognized that the compensation structures and elements need to connect with larger strategic elements, as well as you have to have strong governance structures, effective management of practices, IT platform that's effective, data-driven performance monitoring, and other types of processes in place to be effective as an organization. So with that introduction, I think I'll turn it over to Maria to go through what we're finding in the surveys this year.
Thank you, Josh. I will jump right in with an overview of our survey so that our listeners will understand where the data that I will be presenting shortly comes from. Our surveys, our compensation survey, really evolved and emerged from our experience of working with medical groups and integrated health systems on their compensation plans and their redesign efforts. And so we have been doing this for 17 years as our clients have asked us for really information, better market benchmarks, information about what other organizations are doing with respect to their provider performance and physician compensation plans. And so it has evolved over the last 17 years. We started in the Northwest, and it now is a national survey. 10 years ago, we started a pediatric subspecialty study for the same reasons. Our pediatric organization clients were in need of pediatric-specific benchmarks, and so we began that study 10 years ago, and it has grown substantially. We also do CPT provider profiling as a result of the data that we gather through our surveys, and we have a medical group cost and staffing survey that we began a few years ago and that we'll be conducting in 2017. So while it is a small part of what ECG does, it is we have been doing it for a long time, and we really feel like the areas that we differentiate ourselves with our studies, there are three characteristics that we think are different about our surveys. We believe that the way we collect our data and manage our data and validate and report the data is superior to other industry sources that are available. So we think the data really is the highest quality benchmarks that you can get. We're comprehensive in scope. We not only look at physicians, we look at APP performance as well. We look at benefits, work standards, recruiting, the practice profiling that we report on as well. So for our survey members and our clients, we feel like we're kind of a one-stop shop with respect to provider performance. And then who's in our study? We feel that that's a differentiating factor. Mostly our survey members are large integrated health systems, academic medical centers. We have children's hospitals, obviously, in the pediatric survey. We don't have so much, small groups of less than 10 physicians. 90% of our providers in our study work within groups of 150 physicians or more. So with that said, on slide 18, a few other overview slides about where our survey stands. In 2016, we had 34,000 providers combined between the adult and pediatric study. As a result, we were able to report 91 physician subspecialties, 50 adult physician subspecialties, 51 pediatric subspecialties, 17 provider types. And of that 34,000, 26,000 was in the adult subspecialties, of which nearly 6,000 were APP providers who practice within 80 organizations. So we've seen, since 2012, almost a doubling of our sample size, and we continue to work on building that while maintaining the characteristics that we value in our survey. On slide 19, this is just a representation of where our members come from. You see here on the blue dots are the adult organizations. This really represents where the corporate offices are for many of the organizations. We have several survey members who have providers practicing in several states or across the country. So we've just listed here where their corporate location is and a few of the members who participate in the study. We have a comprehensive list of members of both the adult and pediatric surveys in Appendix A if you are curious as to who are in the benchmarks that I'm about to present. And on slide 20, the last overview slide, as you see here, 91% of the providers in our 2016 final data set work within integrated health systems, 9% in independent medical groups. The survey really has just mirrored what's happening in the market over the last several years as physicians align themselves more with integrated health systems or become employed by academic medical centers straight out of residency as opposed to setting up private practice. So as we have fewer and fewer independent practices, our benchmarks reflect that trend. Also, as I showed on the map, we have good geographic representation in the study. 40% of the providers are practicing in the West region, while we have 24% in the Midwest, and the remaining in the East and South. We actively look to increase our sample size in each of our regions as we move from year to year. And then the last data point I'll mention before we get into some findings is that 85% of the physicians in our final data set this year are established physicians who have been with their organization for more than 2 years, while the remaining 15% are new physicians who have been there for more than 1 year, but not quite 2 years yet. So, with that said, let's jump right into some physician performance trends on slide 22. So there are a few background pieces of information I'd like to give before I get into some of these findings. We report through our survey 36 compensation, production, and benchmark compensation, production, and benefit benchmarks by specialty in our results. We take that provider level data and we summarize it into each of the physician specialty categories in order to give our listeners and our survey members an understanding of what we think is happening in the market in terms of provider performance. On this slide, we are presenting primary care and what has happened from over the last few years. Primary care in this case represents the family practice without OB, family practice with OB, internal medicine, and general pediatrics. When we speak of compensation and production metrics in this table on the right, these are normalized clinical earnings and production figures based on each provider's clinical effort. So this represents what we normalize each provider's data in order to see and compare year over year how they're performing. And then the last thing I'll mention about these statistics is that we take a subset of physicians from 2015 and 16 to see how their data changed year over year. We recognize that we have different membership from year to year in the study. We also know that providers leave organizations and may be in their data set 1 year and not the other. So when we look at, well, how did compensation change? How did production change? We want to look at actual providers and compare their performance year over year. And so with that said, primary care compensation, as you see here, increased by 1.5% over 2015. It's a modest increase, but yet it's still an increase. It's more modest than what we saw in 2015. Each of the primary care specialties increased over 2015, with the exception of internal medicine, which stayed relatively flat. It was a negative 0.4% change over 2015. So we saw family practice and general pediatrics increase slightly over last year. With respect to work RVUs, we saw a decline, which is a change from what we saw last year, where it stayed flat. That was a 3.6% reduction in the RVUs generated by these providers from last year to this year. The impact of that reduction really was a pretty significant increase in compensation per work RVU of 6% for our primary care physicians. That increase of 6% was seen across the board, except for in internal medicine, whose rate went down by 2.5%. And so, these rates, and I'll talk a little bit about compensation and to work RVU rates in a couple slides, and how we can look at some of these benchmarks and how to address these changes within your compensation plan. Net professional collections increased by 6.4% over 2015. We really think that this can be attributed to service mix changes, and we know that because we have CPT data and we can drill down into it and see how physicians are practicing differently. Payer mix, the amount of commercial revenue coming into the groups, and revenue cycle performance. The AR for our survey members improved over 2015. The average current AR for our survey members was 57.7% this year, and the days in AR went down from 38.4 days to 35.2 days. So those are real changes that impact net collections in our groups, and really show that our groups are focusing on their operations and their revenue cycle performance. On slide 23, sticking with primary care, although we're presenting data for nationally and not showing you geographic cuts or cuts by practice type or tenure or what have you, I do want to let you understand that there obviously are geographic differences in how physicians are paid across the country, or how much they're being paid. The highest primary care compensation levels are being seen or experienced in the West, and the compensation per work RVU rates are also the highest in the West. The lowest rate is being paid in the Midwest, and they also are paying the lowest compensation levels for primary care. We know that this is consistent with what we're seeing in reimbursement rates also. So there's a lot of alignment between how organizations' contracts are set up and how their reimbursement rates are with their commercial contracts. There's a lot of parallels between that and the levels being paid to physicians. So we know in the West Coast, in California in particular, the commercial contract rates sometimes are double what we see in the Midwest and the Southeast. Slide 24. So moving on to the subspecialist or specialist compensation. Similarly, we saw an increase, a little bit more so than what we saw in primary care. Compensation increased by 3.1%. This is consistent across all specialty categories: medical, surgical, and hospital-based. The work RVUs, again, decreased for the subspecialists, but not by as much as what we saw in primary care, decreasing by 1.2%. The compensation per work RVU rates increased by 7.4% for this group of physicians that we analyzed. I will caveat that number a bit because the hospital-based physicians really impacted that increase in the rate. The medical and The medicine physicians, their compensation per work RVU rate went up by 1.9%, and the surgical physicians went up by 2.9%. So the hospital-based physicians in the data set really bumped that overall compensation per work RVU rate up. And then again, in the next professional collections here, we saw a decrease, which can be attributed to service mix as well, and somewhat maybe the total RVUs decreasing pretty substantially by 3.7%. On slide 13, as I mentioned before, or slide 25, as I mentioned before, when I'm talking about this compensation per work RVU benchmarks that we report out by specialty, now our survey members and our clients get access to the benchmarks both nationally, and they can cut it every different way from geography, tenure, organization, ownership type, variety of different demographic filters. But what we really wanted to understand, and what our clients are starting to question, is when they look at these national benchmarks, they recognize that there's some noise in the data, meaning that we have some physicians who are lower producing in the benchmarks, and we have some physicians who are higher producing. So those who are lower producing, we know that in many cases those new physicians have minimum guarantees, so they're protected on the downside. On the high side, high producing physicians sometimes have caps in place so that they can't earn more than some level, which effectively reduces the rate that they're paid. So we wanted to better understand, what these physicians were actually earning per work RVU. And so we divided each of the physicians in our data set into 4 different quartiles: those who are producing less than the 25th percentile, those producing between the 25th percentile and the median, those producing between the median and 75th, and those producing higher than the 75th percentile in terms of work RVUs. And then we looked at the data sets and said those physicians producing between the 50th and 75th, we're going to term those better producing physicians. Those are the ones really that likely are where you want your physicians to be. And most of your physicians, once they're successful, will be producing in that range. And said, what are these physicians earning? What are their effective compensation per work RVUs? And we did this actually as part of an article that we're writing with Dr. Ken Robbins at Hawaii Pacific Health, and then my colleague Dave Wofford here at ECG, that's going to be published in HFMA in 2017. And our findings were confirmatory. We realized that these physicians, these better performing physicians, were actually earning, up to, on average, 10% less than the national, all-in benchmark. And across the board, primary care, medical, surgical, and hospital-based. So, what does this mean? And we know that organizations are taking a more critical eye, a critical view of market benchmarks. They're not necessarily just taking the national number and saying, okay, this is the rate for this year. We know that we encourage organizations to use multiple benchmarks from multiple studies, possibly even using rolling averages. But this is really something else that organizations are looking at, is saying, okay, let's look at our strategy. Let's look at our financial standing. What can we afford to pay? What really should we be paying these physicians in the better performing cohort, as opposed to, that all-in number. So we get these questions all the time, and we're going to be tracking this over time. This was the first year that we came out with the better performing benchmarks. On slide 26, as Josh mentioned, we have physicians who are being paid across the different types of practices differently. Some who lend themselves to being paid more in salary, and more others who have variable incentive plans. But we track this as a survey. We want to understand what's happening in the market. Is there a wholesale change? Are groups moving towards implementing salary plans as they move towards value-based care? And the short answer is no, they're not. I mean, we still see about the same percent of providers being paid, or physicians being paid on a straight salary. Most of the 16 to 17% paid here under a straight salary are new physicians, or as Josh pointed out, the new programs where maybe the organization doesn't have the volumes to support a production-based or a variable incentive plan. So we still have 84% of the physicians that are being paid under an incentive plan. Most of those are on some sort of 6+ bonus compensation plan, where they are either have a minimum guarantee, or at a minimum have a draw in place so that they can maintain consistent compensation. And then moving on to slide 27. So we have gathered information. We want to understand, we know that there's variation, similar to that compensation per work RVU benchmark that I mentioned. We know that there's variation in how new and established physicians are being paid by specialty category. And so we really wanted to understand, how are new physicians within the different specialty categories being paid? How are new APPs being paid? And then how are the established physicians within the categories and APPs being paid? And so here what you see on slide 27 is that 2/3 of the organizations are paying new physicians under a salary. And 1/3 indicated that they put their new physicians, right on some type of variable compensation plan, whether it be the established physician compensation plan or not. It is variable in nature. With the new APPs, 85% of the organizations are paying new APPs on a salary. As they move to the established provider category, meaning more than 2 years within that organization, a majority, from 2/3 to 86% of physicians move to a variable incentive plan. Some stay on a salary. Again, some of those may be hospital-based specialties or new programs. And while with the APP providers, we're seeing a majority of those still stay on a salary plan as they become established providers. Another data point that we do report on in this study is, the income guarantee length for different types of physicians. So, how long are you guaranteeing the income for primary care physicians? Is it 1 year, 2 years, 3 years, or not at all? The number that we arrived at this year for our survey in primary care, 58% of the organizations indicated that they have a 2-year income guarantee for primary care. 52% indicated a 2-year income guarantee for medicine, 57% for surgical. In hospital-based, it was just 39%. The remaining physicians who aren't on a 2-year plan, most of those are on a 1-year income guarantee. So we have seen an acceleration, and we'll be tracking this, an acceleration of getting physicians off of that new physician salary plan to the incentive-based plan, and we see that moving from the 2 years to the 1 year, and we'll continue to track that next year to see how fast that moves. On slide 28, we also collect a whole host of information around how physicians are being paid, their compensation plan methodologies, how the market is moving to incorporating non-production incentives, how many organizations still are using RVUs. And as you see here on slide 28, a majority, 76% of the organizations are still incenting physicians based on their RVU production. But we've seen quite a significant growth in the number of organizations and the percent of organizations incorporating non-production metrics such as quality and patient satisfaction. And then we have, across the different survey members, they have profitability, collections, panel size being looked at as well. But we've seen quite a bit of growth in that in quality metrics being incorporated.
Maria, just to interject really quickly, I think a lot of the work that we're doing right now is focused on defining what these elements are, and I think much of the work that many organizations have in front of them is to define what actually defines physician performance. And so when we think about quality or access or panel size or other types of metrics, as soon as you tie dollars to those metrics, they are focused on very significantly by the provider community, and making sure that those definitions are clear and consistent and aligned with an organization's priorities is critical to do that. So that I just wanted to interject that really quickly.
Thank you, Josh. On slide 29, along with what Josh has just indicated, we have collected in the past information from survey members about what quality metrics they're using within different specialty categories to incent physicians, and we know that there's a lot of variability. It depends on so many things: the strategy of the organization, the types of payers they have, everything. So because of that, we still want to understand, well, how much is at risk for quality within the different specialty categories, and what is the average payment being paid to the different physicians. And so on this slide here, you see that most of the physicians are being paid between 4 and 6% of their total compensation is dependent upon quality, achieving some sort of quality metrics. And that translates on the right side to the $12,000 to $20,000. We actually collect quality earnings and patient satisfaction earnings at the provider level. And so we know these numbers by specialty, not just by specialty category. And our survey members have access to that. Similarly, with APPs following the physician approach to compensation, 7.7% on average for those who are paying for quality. 7.7% is dependent on quality, equaling $9,300. So moving right along on slide 30, just to touch briefly on provider benefits. Again, no conversation about physician compensation or APP compensation would be complete without looking at the benefits. We do dive into benefit plans and packages for physicians and APPs, as well as staff. And we look at how much each of the benefit components is costing our survey members, both by components such as, for the health, life, disability, retirement, etc., as well as in as a whole. And here on this chart, you see that as a whole, benefits increased slightly over 2015, the actual cost to the organization. As a percent of compensation, it also increased to 16.5% for physicians. As opposed, the APP benefits actually declined, and as a result of the declining cost of benefits for APP, as well as APP compensation increasing, which I'll go over in a moment, the benefits as a percent of total compensation fell for APPs to 20.6%. The only two other things that I'll highlight about physician benefits is that this year, 61% of the organizations indicated that they are paying partially for the premium, for the healthcare, for the premium for the provider, for the physician, their spouse, and dependents. That's down from 68%. We saw a slight increase in the number of organizations who reported that they're paying 100% of the healthcare premium for the physician, spouse, and dependent. So we don't know really if that is a trend because it's just the first year that we've seen that number increase in the 100%. It has been trending down for many years. So we're going to keep an eye on that, and we'll be able to come back next year and let you know if that's something that, because of increased competition, organizations are beginning to go back to. So we just have a couple more APP slides here on slide 32 before we get to your questions. You know, similar to physicians, these are the three primary provider types that we have the most sample size in. Compensation for nurse practitioners, non-surgical PAs, and surgical PAs increased. They've increased quite a bit for the nurse practitioners. That's mostly driven in our data set by including some for-profit APPs, and you know, that's a whole topic for another day. But we know that these nonprofit or these for-profit organizations aren't really, you know, concerned with the START laws, and they're not really held to the same standards, so they can pay more than our hospital clients. And so, you know, we're going to be keeping track of that and seeing how that's the impact of that influx of new providers in the market, what the impact on physicians and APPs are over time. On slide 33, just numerically, the change for nurse practitioners and PAs, that nurse practitioner number again went up quite a bit over 2015, but also the surgical PAs did. Slide 34, just another graphical representation of how these providers are being paid under the variable compensation systems, and how that changed from last year. Fewer are being paid under a straight salary. Again, the nurse practitioner number impacted by the influx of we've really doubled the sample size for nurse practitioners from last year to this year, which I actually think is a good thing. The more sample, I think, is more representative of the market. But as you can see here, they're being paid both under a salary and variable system. And then lastly, on slide 35, and we do collect a bunch of information of how APPs are being paid, are being utilized, how they're being utilized, what their roles and responsibilities are, what their duties are. You know, here at a very high level, we know that within organization, on average, we see for primary care, medicine, and emergency, like 1 APP per 2 physicians. For the surgical PAs, we're seeing more like 2 PAs for every 3 physicians. And then on slide 36, you know, just at a high level, again, we know that our organizations are using a blend of APPs, both working independently with their own panel. Some are just using them as extenders. Some are doing both. You know, they have some APPs who have their own panel, some that are extenders, and so it's a blend. But we do know, we have a bunch of information about what these providers are doing in the inpatient setting and outpatient settings, such as diagnosing, ordering tests, prescribing drugs, or, you know, are they doing admitting, discharging, taking call, and things of that nature. So if you have any questions about that, I'd be happy to you know, schedule a call with you. And then before we get to your questions, I just would like to thank you for being here today and let you know that I will be reaching out to you to see if you have any questions about what we presented today, and tell you a little bit more about how you can get access to these benchmarks and more by participating in our 2017 survey. So with that, Matt, that concludes our formal presentation, and I think we're ready to go to any questions that came in during the presentation.
Yeah, great. Thanks, Maria. First, as a reminder, please continue to enter your questions in the question and answer pane at the right of your screen, and I'll ask as many questions on your behalf as the time permits. And so with that in mind, we've had a couple of good questions, and why don't we tee up this first one. Josh, this is for you. On slide 12, you discussed the different dials that comprise physician compensation. And one of our participants would like to know is, how do you see surgical subspecialties such as urology, dermatology, ortho, how do you see those subspecialties fitting into that configuration?
That's a great question. I don't know if we can go back to page 12 just to visualize it, but today most proceduralists or highly procedural-based specialties are pretty significantly fee-for-service and productivity oriented. So I would typically those are characterized towards the right-hand side or on the production-based side of the spectrum, where most of their compensation or the preponderance of their compensation is derived based on productivity. More and more for those surgical specialties, value components are being injected in addition or in conjunction with those productivity-based incentives, but by and large, they're productivity-driven specialties.
Great, thanks, Josh. And we've got a couple more questions coming in, so I don't know if it's possible for us to go back a couple of slides, but we do have some questions regarding on slide 22. We were talking about the primary care physicians, Maria, and primary care compensation. We were looking at specifically the years between 2014 and 2016. Do you have any kind of explanation, Josh or Maria, in terms of just some of the percentage variances that we're seeing in the most recent 3 years, and just what you kind of attribute some of those trends to?
Yeah, this is it's interesting because sometimes what we see in the changes is the impact of the growth of the organizations, right? So, as we see our organizations go from 75 physicians to 210 physicians over a short period of time, we do have physicians that, while they're maybe more than 2 years in the organization, are still really ramping up. And so we do see that some of the numbers are coming down. I do also think that as that there's an impact of the baby boomers in here that it's just hard to quantify at this point. We are collecting age of providers in our data set, but we know that after the 2009 recession, we had a number of physicians prolong their retirement, and now those physicians are moving to a part-time practice, slowing down, and I think that also has impacted our benchmarks in the last 3 years.
Yeah, and let me interject too. I think those are good points. In addition, we've seen just a significant amount of acquisition and consolidation of physician practices from independent status to an employed status, and we've seen it time and again where productivity declines and compensation increases just due to the structure of an acquisition. So I think that there's some of that going on in the benchmarks as well.
So we've got a couple of questions on this next one. In terms of the percentage allocation of compensation or quality in the compensation structure, we had talked about in here that we saw it generally ranged anywhere from 4 to almost 8% when you think of APPs, but when you think of it just the physician subset of PCPs, medical, surgical, hospital-based, it was in the 4 to 6% range. Obviously, that's based on data collected by the ECG survey. I'm just wondering, Josh and Maria, in your opinion, do you ever see what are kind of the opposite ends of the spectrum you see in terms of the magnitude of dollars put at risk for quality, and does that differentiate at all by regions across the country?
Yeah, let me take this, and it's a good question. I'll caveat too. You asked quality. I'm going to expand the definition to non-productivity or value-based metrics. I would say that there is significant amount of work being done to increase the total proportion of compensation tied to these other metrics. So we have clients right now who are currently maybe paying about 10% of total comp on average based on those value-based metrics. They're pushing to 15 to even 20% of compensation tied to these things. So I think those are pretty advanced organizations that have bought into fully kind of a value-based world and perhaps have a higher proportion of their reimbursement tied to things other than volume. So 20% is a pretty aggressive number. There are places that are higher than that, but I think there are fewer and farther between. I think the lowest on the end of the range, I think every place that we're at have some dollars or some amount tied to value, and so the lowest amount we see is perhaps maybe 3 to 5%. So that's generally the range. In terms of geographic variability, I want to be careful of time. There are regions that are still significantly fee-for-service oriented. So places in the South, like Atlanta, Georgia, and other places, tend to have a lower proportion of overall revenue tied to value, and so their compensation arrangements correspond. But places in the Midwest, Upper Midwest, like Michigan, in the West Coast, California, Seattle, Pacific Northwest, have a higher proportion of dollars tied to value-based, just due to the reimbursement economics.
Great, thanks, Josh. I know we got time for one more final question, and for those of you that have asked questions, and I'm not going to have a chance to put those to Josh and Maria, we will follow up with you offline. So I'm just going to read one more here, and then we'll wrap things up. So, and this is for Josh and Maria, but we have hired a group has hired a large number of APPs in the past 12 months, and they're working on trying to come up with a consistent approach to compensation for these providers. How are you seeing organizations engaging and thinking about structuring the compensation plans for APPs, and how does that correlate with how physicians are compensated?
Josh, I'll let you handle that.
Yeah, so I think there's usually, I would say this is a longer answer than I have time for, but usually there's 3 or 4 approaches to compensating physicians for supervision. One approach is to not compensate at all, and just to assume that the supervision is just part of being a physician, and there's no separate payment oriented or required. From there, the next simplest approach is creating a stipend that says, hey, we recognize there's value and risk, frankly, that the physician takes on by supervising an APP, and having a flat stipend on a per APP supervised level. And then we see variable models, some based on RVUs or some measures of APP productivity, where physicians get some portion that's appropriate for the amount of supervision that's given, to the fully risk model, where you take the revenue generated by the APP less the direct and indirect expenses, and that creates an amount available for physician compensation. So we're seeing a variety of those being in place, and the differences are based on specialty type, how the physicians utilize APPs, and what level of effort and complexity are required to supervise those. My last caveat will be to say is that all those arrangements must comply with fair market value and commercial reasonableness. And so when we think about total comp, they need to be taken into the context of how you're paying for other elements of a physician's activities.
Great, thanks, Josh. So we have come to the end of our program this afternoon. I would like to thank again all of you for attending today's presentation. We hope that you'll be joining us next year for our 2017 Physician Compensation webcast. If you have any additional questions or comments, please do not hesitate to contact one of us via the email information provided on the screen and in the handouts. One final reminder, we would greatly appreciate it if you could take a moment to complete the electronic survey upon exiting today's program. Again, there'll be a donation made to Doctors Without Borders for each completed survey. We thank you again for your time, and have a great afternoon.